Hello, everybody. My name is Catherine Pulaski, and I'm excited to share my work with you today. I first wanted to acknowledge all the individuals in this conference and those who are not present that are working tirelessly to treat, prevent, study, trace, whatever it may be, develop protocols, and to the ever pretentious COVID-19 pandemic. And I thank you from the bottom of my heart, and I salute you in in continuing that work. I do also want to acknowledge the ever omnipresent racism pandemic that has gripped our country since its inception. I want to pay respects to those who have lost their lives, their identity, and their self-worth, and beyond for nothing more than being exactly who they are. I want to acknowledge my privilege here today in this space as a white woman in academia, and recognize that my social identity has allowed me to be accepted fully in this community. I also want to state that this body of work was developed and completed as my master's thesis project for the University of Washington School of Public Health. And it included a committee of brilliant professionals in the field whom I will introduce in a moment. So let's jump right in. I'm going to share my screen with you all. Awesome. So as you can see, the title of this body of work is Medical Dental Integration in a Rural Community Health Center, a Qualitative Program Evaluation. And the authors include myself. I am also a clinical dental hygienist with the, obviously, as I told you, recent completion of my MPH at the University of Washington. And next is Dr. Joanna Cunha Cruz and Dr. Kirsten Centuria, who are both faculty at the University of Washington. Dr. Juliana Hilkert, who is visiting faculty from Brazil, and then Dr. Stephen Davis and Mark Code of Yakima Valley Farm Workers Clinic. So yeah, let's jump right in. To kind of give a little bit of background here, I wanted to start with some Washington State specific oral health stats. First, actually this is a national kind of stat, but dental caries is the most common chronic disease in children, and prevalence is especially high in Hispanic youth in the state of Washington at about 57%, and this is from the most recent NHANES data. And at least 25 out of the 39 counties in the state don't have enough dental providers to really meet the current and growing needs, dental needs. And according to HRSA, actually Washington State would really require an additional 300 plus providers to remove its status as a designated health professional shortage area for dental care. So for those of you who haven't heard of the concept of medical dental integration, this is actually one way that community clinics are attempting to bridge that gap and those disparities. It's more than just co-located clinics and enhanced referral processes. It really requires organizational and system changes to engage a diverse workforce to change administrative and clinical practices. So why are we considering this? Well, as a dental provider in the dental, the dental community, we've really been connecting those dots between oral health status and chronic disease, and so has the medical community. So things like Alzheimer's, diabetes, heart disease, those types of chronic conditions, they have a bidirectional role in oral health status. So now patients, parents of patients are really starting to value achieving that optimal comprehensive health for both oral health and full body health. So for years, as we all know, it's still practiced this way today, but medicine and dentistry obviously are two separate practices, and they're really lacking that intentional open line of communication and coordination of their shared patients. So, and that's something that I've experienced as a clinician as well. But as we're starting to make these connections of oral health and systemic health, in our current fragmented health system, it's really not set up to communicate and collaborate efficiently. So that's where this idea of medical dental integration comes from. And there have been previous strategies and previous research on those strategies, and that research really includes process evaluation of case studies, pilot programs, but really haven't had any reporting out of health outcomes. Typically these studies have assessed the acceptability, feasibility of different integration models, such as, in those previous strategies are incorporating screenings or referrals for chronic diseases in the dental practice, integrated electronic health records with dental records, or training primary care providers on how to provide basic preventative services and oral health education. Really at this time, no system level studies, no experimental studies. One case study in Colorado actually mobilized a dental hygienist as a provider in a medical practice where the hygienists essentially offered education and preventative services. Their target population, though, was majority white children aged 0 to 3. So to jump to our study aims, really our aims of this study were to elicit the perspectives and experiences of providers, administrators that were involved in a MDI, medical dental integration program that was implemented by a community health center in Eastern Washington to assess the acceptability, feasibility, and success of that model. So I do want to give you a little intro to, or a little information on that model, essentially that they implemented. So this model focuses on serving low income, mostly Hispanic children in a rural community. And it's a pilot program aimed to expand access to care. They utilized 2 full-time hygienists that worked with the administrative and medical teams in 2 separate pediatric clinics. They performed oral health services, or excuse me, oral health assessments, caries risk scores, health promotion education, preventative services, dental caries preventative services like fluoride varnish or silver diamine fluoride, and care coordination and dental referrals when necessary. And all these services were done by the hygienist during well-child visits for children 0 to 5 at 2 of the pediatric medical sites. So I'm just going to kind of briefly go over methodology. Obviously, this was a qualitative study, so propositive sampling was utilized to identify and select participants. Originally, we did want to include patients and caregivers who participated in the program, but limitations to the COVID-19 pandemic right around that time of interviews really made that impossible. The clinic closed. So before then, I conducted semi-structured key informant interviews over a period of about 2 months. From January to March over the phone. And these were interviews with dental providers, medical providers, clinical administrators. You can see the representation of our study participants and how we classified them based on their roles. We have a nice spread of medical, dental, and administrators, all who have been there for various amounts of time. The interview guide was developed and based upon using the Agency for Healthcare Research Quality's AHRQ's framework for measuring integration of behavioral health in primary care. So we did modify it for dental health in primary care, and I'll show you a representation on that in the next slide. Again, informed by grounded theory, a general inductive open coding methodologies was executed, and these were synthesized into theme domains. Really quick, here's the framework. I kind of created this visual, but I wanted you to see that there were 10 mode domains. We utilized 9 out of the 10 because that 10th one, the business model sustainability, the CHC was actually already doing an evaluation of that already. So we did not need to do that with them. So here our data revealed essentially 3 major themes, each with their own subconcept. So first, that the program is, the MDI program is feasible and acceptable with key considerations regarding setting. And I think that's very important because those considerations included charting integration. They were able to integrate their medical and dental charts electronically, familiarity with service integration. So they had previously had behavioral health specialists, nutritionists, those types of people already going into some of these primary care visits, these well-child checks. Progressive leadership, so the leadership that kind of brought this this idea of the program to the staff, clear communication between leadership and that staff, and then the relevancy of a dental hygienist for integration. So really utilizing that dental provider in the medical clinic itself. So second large theme was implementing, this implementation really faced systemic, structural, and behavioral barriers, such as reimbursement challenges, typically, mostly from Medicaid, planning phase miscommunication between those who were implementing and those who were expected to perform, and be involved in the integration, and then discrepancies in the demand for services. So it's interesting that because I mentioned before, there were 2 separate pediatric clinics involved in the program that implemented the program. So one clinic actually had a really large amount of demand where the hygienist couldn't see each kid that wanted to be seen or could be seen that was eligible. And then on the flip side, in the other clinic, they actually had to expand, the age range from 0 to 5 to 0 to 18 because they just didn't have enough kids for her to see. So I thought that was interesting too. And then lastly, the third kind of largest theme is the program is perceived as beneficial and successful, in terms of patient outcomes, services provided, and increased access to care, which is the whole idea, right? So I did include some quotes. I included about 5 quotes in the PowerPoint, but I'm just going to read a couple here for you. So first, an administrator noted, the one follow-up that we had is that it wasn't receiving dental reimbursement because we were having a hygienist see patients that were coming in for well child checks, and the checks have a component of dental screening that occurs even though that screening is very different from what a dental hygienist is performing. That's why the healthcare authority decided that we can't double dip in that, but at the same time, the services being given were very different, or excuse me, drastically different. So I thought that was fairly interesting. So that was from an administrator. And then a medical provider noted, there was an instance where I had a patient who was very concerned about a dental abscess, which is not something we get a ton of training on. I said, okay, I'm going to have the dental hygienist come in next. She'll take a look. And then we were able to connect them upstairs, get an appointment right away to take care of things. Otherwise, would it have happened that day? Probably. It would have taken me going out of the room, walking upstairs, finding a provider. 15 minutes later, I'm back onto the floor and I have 3 patients waiting for me. So I think these quotes do well to describe not only the themes, but the difference between medical and dental services, and how they're not the same, but they should be incorporated at the same time. So integration, right? So I have a few other quotes, one from a dental provider really just talking about that they had captured patients that they were missing. People were being seen in medical, but weren't being seen in dental despite that co-location of care. Another medical provider noted they already had integrated services, so it wasn't super tough for them to introduce a new provider into their well child checks. And lastly, an administrator had just talked about the dental hygienist as being very flexible, passionate about the community, being part of the community, and just was kind of an ideal provider from that end. So I think some key takeaways here that I'd like everyone to really understand is that this particular model, medical dental integration model, is acceptable and feasible in a community health center setting by medical and dental providers, but also the administrators. And although that may be acceptable, which is great, if reimbursements don't follow these services, the program may not be able to last or be sustainable. So right now in Washington State, the healthcare authority does not permit billable dental services where an oral health screening by the medical provider is expected to be done during a well child check, which it is at this moment, particularly when there's a dental clinic in the same location, which is the case in this CHC. So despite that co-location of care, again, participants noted that some children that were actively attending medical appointments were not being seen regularly or at all by the dental clinic. And I think this just kind of reinforces demonstrates that co-location is not the same as integration, and that insurance policies are acting as a barrier to medical dental integration. Also, well child checks seem to be kind of the most obvious and natural appointment time to embed oral health services. Multiple providers are already expected to come into the appointment, not only by patients, but, the providers themselves. So they're used to working around each other and utilizing teamwork to make that happen. And I think that makes care more efficient and more accessible. And then lastly, studies that didn't incorporate a provider with formal dental education, like a registered hygienist or a dental therapist, to provide the oral health services, actually noted some barriers that included, things like lack of oral health knowledge, training, lack of confidence in providing those services, which may be a reason that this particular program was considered a success. So really to kind of wrap up and give some concluding thoughts and some next steps. First, medical dental integration has demonstrated that it's really needed to increase this access to dental services. We're all aware of that fragmented healthcare system that we work under, and especially the way insurance policies have a way of dictating someone's healthcare choices. Next, this particular model of medical dental integration, incorporating that dental professional into the medical practice, is accepted by both the medical and dental providers, as well as the administrators who are responsible for ultimately implementing these types of changes in care delivery. Also, we as the research community should be using the results of this study and others to inform kind of additional large-scale research to confirm or contradict these findings as they would apply to other sites in the country, across the country. And then lastly, that, the research community, we really need to understand these long-term outcomes of integrated services for patients and how it may influence, maybe reduce healthcare inequities, and really promote policy development for system-wide healthcare changes. Lastly, just giving some acknowledgements here. Obviously, I want to thank all of my wonderful co-authors who helped make this project possible. Yakima Valley Farm Workers Clinic for accepting this project and accepting this idea that we had, and our Cora Dental Foundation really for connecting the two of us together. So thank you all for your time and your patience, and I hope you learned something today. Thank you.